The kind introduction. Before I start, I would like to thank the organizer for inviting me and giving me this opportunity to come and speak to you on a rather topical subject. Now, this is what I'm going to talk about, sputum, and the actual technique of induced sputum. Now, I could hear somebody at the back saying, "Oh, disgusting." Now, after my talk, hopefully I'll be able to convince you sputum does give us a lot of information, and important information, and it's rather lovable. Okay, it helps us a lot in terms of asthma management. Sputum does go back a long way. Hippocrates actually recognized sputum as a very important substance and labeled it as a main body substance. The presence of eosinophils was only noted in 1889, but it was not until the early 90s that people actually started using sputum to examine for the presence of airway inflammation. And in fact, the first paper on the technique of induced sputum only came out about 15 years ago. The paper was published in Thorax. Now, what has actually happened subsequent to that is phenomenal. I mean, over the last 10 years, looking at the number of papers published linking sputum induction or sputum and airway inflammation, you can tell it's increasing at a tremendous rate. So in the next 25 minutes, I'm going to divide my talk into three parts. The first part, I'm going to tell you something about the technical issue of sputum induction. How is it done? Is it safe? And then the second part, I'm going to share with you some of my research work using induced sputum and in relation to childhood asthma. Last but not least, I'm going to tell you some problems, some limitations associated with this procedure. Now, this slide summarizes quite nicely the actual procedure. So after inhaling a salty water or solution, which is similar to ocean water. Now, mind you, we do not give our patient ocean water. We give them hypertonic saline, which is slightly cleaner. They would then be encouraged to cough up the sputum. Okay, and then we can use the actual sputum to do various analyses. People could measure cytokines, chemokines. But what I'm going to concentrate on is inflammatory cells. Now, we know asthma. Eosinophils are the major players. So the my subsequent talk is going to concentrate on inflammatory cells, mainly eosinophils. Now, the first question you may ask, why bother inducing sputum? Why not just get a spontaneous sample? Now, children are not young adults. Many of them cannot expectorate as easily as adults. But the technique of induced sputum is well tolerated in those as young as 5 years of age. Okay? And induced sputum has been proven to have better quality cells, more viable cells, less contamination, allowing us to prepare better histology slides. And the actual technique is very reproducible. Now, it has been shown the cells in induced sputum has very, very good correlation with those present in bronchoalveolar lavage and also lung biopsy. So we've got a non-invasive way to look and study airway inflammation. Now, nowadays, airway inflammation is very topical. People are always talking about it. Why? Because we know airway inflammation, if uncontrolled, can lead to airway remodeling. Now, that's going to have long-term morbidity or even mortality. So how does it work? To be honest, nobody really knows, okay? It has been proposed that hypertonic saline actually increases the airway lining fluid osmolality, and that's going to increase the vascular permeability, hence the mucus production. Hypertonic saline is a very, very strong cough stimulant, okay? It also stimulates the mucociliary movement, helps to move the secretion from the more peripheral airways to the central airways. So the whole procedure actually helps to bring out the sputum, bring out the phlegm and mucus. Now, this is the unit at our hospital, not very impressive, I'm afraid. We do have a safety hood whereby the actual induction is done. So any aerosol that's generalized, it's going to be sucked out and filtered. We've got a small bench space here where the simple initial processing of the sputum is done, but the actual staining and mixing with the chemicals It's actually done in a proper laboratory. This picture shows my master's student demonstrating the technique. We have to monitor the spirometry on a regular basis. As we all know, hypertonic saline actually causes bronchospasm. Okay, we don't want that to happen, and we don't want the lung function to drop too severely and cause the patient discomfort. As you can see, the actual nebulizer is within the hood. So as I've said, anything that's generalized is going to be sucked out without causing any contamination of the actual room. Now that's the protocol, very similar to the one initially described. We measured the baseline lung function, the FEV1. It has to be more than 60% predicted before we proceed. And we use 4.5 hypertonic saline. Now, for more severe cases, we can use a lower concentration, 3% or even normal saline. They would then inhale the solution in 6 cycles. As stated in the bottom, each cycle has a different duration. After each cycle, the patient or the subject is encouraged to cough to bring up the sputum. And after 1 minute of coughing and bringing up sputum, we repeat the lung function again to make sure the FEV1 is actually more than 80% of the baseline value. If that's not the case, we'd give the patient Ventolin as a bronchodilator and monitor the response. Obviously, the actual procedure will stop once we've got adequate sample, or if the patient does not want to continue, or if the lung function drops by more than 20% of the baseline. So safety, especially in children. As I've mentioned, if your patient has got severe asthma, brittle asthma, you could use a lower concentration hypertonic saline, like 3%. There's always a physician there when the procedure is being carried out. And pre-medication, some units would advocate the use of bronchodilator pre-treatment, i.e. give the patient bronchodilator beforehand, before the induction. One problem with that is that after giving the bronchodilator, the actual yield or successful sputum induction is less, the rate of success is less. Work done by Christiana Lex at the Brompton Hospital, looking at the actual technique, the feasibility and safety in difficult to control asthma. She managed to recruit 40 patients, now median age of 12.4 years, very severe asthma. Why do I say that? Because the inhaled corticosteroid dose is actually up to 2 milligrams, very, very high dose for pediatrics. Now, many of them are actually on second and third line prophylactic treatment, theophylline, montelukast, long-acting beta agonists. And in fact, up to about half of them were taking oral corticosteroids. And if you were to look at the daily use of beta agonists, about 90% were using it on a daily basis, telling us they are still symptomatic despite on such a high dose of corticosteroids. So we're dealing with a difficult control, you could say, maybe touching the brittle asthma group of patients. So 38 actually managed to undergo the sputum induction, and only 4 out of the 38 complained of moderate symptoms, tightness and wheeze, and those symptoms were reversed quite readily with the use of bronchodilator. 10 of them had minor symptoms, sore throat, nauseas, and very transient. So from this data, we can say the procedure is relatively or quite safe in those with severe asthma, and the success rate was reported to be 75%. How about other people? Other people have actually reported success rate to be about 70 to even up to 100%. Now, our group at the Prince of Wales Hospital reported our experience too. I recruited 130 children of a median age of about 11 years old. They were of mild asthma, or had mild asthma, and they underwent the procedure of sputum induction, and we were able to achieve a success rate of about 75%. Now, 3 patients actually prematurely stopped the procedure, 2 because they started vomiting, and 1, he didn't like the taste of the salty water, and I thought he wasn't going to be a good swimmer. Anyway, minor symptoms mainly of sore throat and chest discomfort, transient, and as a whole, the procedure was well tolerated by children. So if you decide to take up this induction procedure at your hospital, I would give you some advice. Basically, you have to try it on yourself first. Then you can know what the feeling is like, and you know how to explain to your patient. Send the parents away, okay? Don't keep the parents in the same room. Otherwise, the child will not do the nasty coughing and bringing up the sputum thing. Okay? Or even bribe them. Tell them, oh, I'm going to buy you an ice cream if you give me a proper sample. Now, the second part, I'm going to tell you something about my research. The first part is going to be on cough. Now, we all know cough is very common. It's a very common symptom. In asthma, it's probably the prominent symptom, especially in asthma acute exacerbation. Cough can be the only symptom. But cough research is difficult to carry out. Why? Because there's no objective marker of cough frequency. Now, we know diary cards, parental reporting are extremely unreliable. And in the old days, people would advocate the use of a tape recorder to measure sort of how many times you've coughed. But we know the recorders are bulky, and they only rely on a single signal, i.e. one audio signal. Whether it's because other people coughing or whether it's because somebody is talking, you would never know. And at Brompton, they've actually developed a cough monitor, very similar to the old days Walkman. Now, this is a very simple machine, actually. It picks up two signals. One is the audio signal, so when somebody coughs, there's going to be a positive response as a noise. They also pick up a diaphragmatic or muscular signal. So when somebody coughs, you need muscle contraction. At the same time, there's a sound signal. So when you see two signals happening at the same time, you can quite readily say this is a genuine cough. And this machine has been validated to be reliable, to be user-friendly, and we have published using this machine in children, and it's very user-friendly. So I decided to measure cough frequency in asthmatic, but in a subgroup of mild intermittent. Now, if you know about asthma, there are four main groups: mild intermittent, and then mild, moderate, severe, persistent. I decided to look at the mild intermittent because people have actually looked at the persistent group, and there's no doubt there's an eosinophilic pathway driving the cough. And I also wanted to assess the correlation between the underlying airway inflammation and the cough frequency. Our hypothesis was that it's not eosinophilic airway inflammation that's driving cough in this subgroup of asthma. We recruited 40 children, median age of 11.5, pretty normal lung function, predicted FEV1 of 83%, relatively asymptomatic if you were to look at the severity of asthma score and the daytime cough score. Now, we actually recruited a cough frequency over a 24-hour period, and our group had a median of 25.5. Another group actually monitored cough frequency in normal healthy children of similar age, and they reported in normal children they also cough at a rate of about 11 episodes per 24 hours. So comparatively, our group had a higher and significantly more cough compared to normal children. Now, this is the actual distribution of their cough frequency over a 24-hour period. As you can see here, when they go to bed at night, they do not tend to cough. Now, that is in contrast with the textbook classical teaching that nocturnal cough is prominent in asthmatics. They tend to cough in the morning. Now, this is not the case. I mean, we couldn't show that. So the coughs were mainly during the daytime. We then analyzed the correlation between cough frequency and the various lung function and airway inflammatory markers. Surprisingly, we were able to demonstrate a very strong correlation between sputum neutrophils and the cough frequency. The bottom curve is actually the scatter plot, showing you a very good correlation between the sputum neutrophils and the cough frequency. This work has been published in Thorax, and we are probably the first group to provide evidence that in mild intermittent asthma, there's increased cough, and this cough is not driven by eosinophilic airway type of pathway. It's actually dependent on neutrophilic inflammation. Now, this is the first step. We'll probably need another study to support our findings to see whether reducing neutrophilic inflammation would actually reduce the cough frequency. The second study I want to share with you is the use of airway inflammatory markers to help us, to guide us whether and when to reduce the dose of inhaled corticosteroids. Inhaled corticosteroids is very important as a prophylactic treatment in asthma, but we know unnecessary high dose can have complications. A paper published in BNJ about 5 years ago documenting a patient on relatively high dose of Flixotide presenting with hypoglycemia. And nowadays, in our clinical practice, we tend to use symptoms, lung function, and the use of Ventolin as our marker to tell us when to come down on the inhaled corticosteroid, when to go up. But that may not be the right thing to do because we know symptoms, lung function have very, very poor correlation with the underlying airway inflammation. Now, airway inflammation comes up again. That's the buzzword nowadays. Nowadays, we know symptoms are no good. And patients with severe asthma can have relatively normal lung function too. So we decided to study stable asthma, and by definition, they have not been using the Ventolin for more than 3 times per week, and there's no need to change their inhaled corticosteroid dose. And we reduce their inhaled corticosteroid by half every 8 weeks. Now, before the actual reduction, we measure the exhaled nitric oxide, we reduce them, and we measure the exhaled breath condensate. A failed induction was defined as patient becoming symptomatic needing the use of beta agonists for more than 5 times per week. Now the table shows you the baseline data. We had 40 children, 12 years of age, and relatively a normal lung function too. Now that's the flow chart. So after visit 1, 10 exacerbated, so reducing the dose by half, 10 actually could not tolerate that. 1 came off corticosteroids. At visit 2, 3 exacerbated. Stop reduction, basically the patient was actually symptomatic, so we thought clinically we should not have reduced the corticosteroids. So at the end of the 4 visits, 16 actually successfully came off the corticosteroids and 15 actually exacerbated. And we were able to demonstrate that those who exacerbated had much higher exhaled nitric oxide and sputum eosinophils than those who did not exacerbate, who came off the steroids successfully. And using multiple logistic regression and controlling for various confounders, we were able to show sputum eosinophils and exhaled nitric oxide more than 22 parts per billion to be significant predictors for fair reduction. And looking at the various sensitivity and specificity, having eosinophils in your sputum would basically have a very, very perfect sensitivity to tell you that you are not going to be successful in reducing the inhaled corticosteroids. And this paper has been published in the Blue Journal, and basically we're the first group to show in pediatrics the use of airway inflammatory monitoring is actually beneficial and good to guide you as to when you should come down your inhaled corticosteroids. Now this is hypothesis generating. And the next step to do is to do a proper RCT to see whether the use of this inflammatory marker is going to help you and to be beneficial in the actual patient care. And this has been done, but in adults, published in the Lancet by a group in Leicester. So what they did, they approached 108 patients. 74 were randomized, 1 into the sputum control group, 1 into the BTS. BTS stands for British Thoracic Society Management Group. In the sputum group, they didn't care about the symptom, they didn't care about the lung function, they only wanted to know the sputum. They wanted to maintain the sputum eosinophil to be less than 3%. If it's more than 3%, they would step up on the inhaled corticosteroid dose. If it's between 1 to 3, they would maintain the same dose. If it's less than 1, they would come down on the inhaled corticosteroid dosage. Whereas in the BTS group, symptoms were important as well as lung function. So that's what we do nowadays. And they were able to follow the patients for 12 months. Now that's the baseline data. Basically, no significant differences between the 2 groups in terms of age, atopic status, lung function, baseline symptoms, and also airway inflammatory markers at baseline. Over 12 months, as expected, the induced sputum eosinophil was lower in the sputum management group. Likewise for the exhaled nitric oxide. The symptoms and the use of beta agonists and lung function were similar at 12 months between the 2 groups. But what was striking was the asthma exacerbation. Looking at the sputum group, much less severe exacerbation, i.e. they need to seek advice, even admitted into hospital. And that difference was actually already there after 1 month. So we have solid evidence to tell us monitoring airway is actually better. Monitoring the inflammation is the way to go. And they've actually done a post hoc analysis, and this monitoring method is actually cost effective too. So hopefully I've given you some evidence and information about sputum induction, and I think looking at airway inflammation is probably the way to go. But the technique has got limitations. It is very expensive. You need somebody dedicated to carry out the work. It's quite time consuming. For one patient, you need probably about 45 minutes for the actual induction process. For processing the sputum, you need another 2 hours. It is still very much a hospital-based procedure, and it can be uncomfortable. They can have transient sore throat and chest discomfort. And comparing the 3 non-invasive airway inflammatory markers, nitric oxide is easy, gives you the results straight away, pretty good repeatability, but it has to be, it's very individualized. We are seeing data that tells us that severe asthmatic can have very, very low exhaled nitric oxide. Exhaled breath condensate is relatively quick, but problem with dilution and saliva contamination. The sputum process, I guess I'm biased. I think is a very good method to monitor airway inflammation. As I've said, it's expensive, it's time consuming. Paper published last year looking at use of another marker in sputum. Less costly and can have the result within a short time period. Last but not least, I would like to thank various people, and especially the group at Brompton, where I actually picked up the technique under the leadership of Andrew Bush, and the various people, the respiratory team at the Prince of Wales Hospital, and the very last people, my son. Even though I haven't been able to spend much time with him because of work commitments, he has always been very supportive. Looking at this and saying, "Oh, Daddy, don't go yet. I'm going to give you a sample of mine for analysis." Thank you very much.
謝李教授個精彩嘅演講，咁就而家可以問題目嘅，咁就大家可以用英文發問又得，用廣東話發問又得，普通話都唔得喎。大家有咩問題咁啊？關於呢個好新嘅方法就係用痰言入邊嘅eosinophil嚟 monitor 嗰個哮喘嗰個治療方法。或者我問一個問題咧，就係阿榮，究竟有冇可能喺一個 day-to-day practice 嗰度用？即係你嘅 limitation 嗰度講到話都好麻煩，45分鐘亦都比較貴。咁但係俾一個普通醫生、兒科醫生或者係家庭醫生睇好多哮喘咁樣，有幾實用咧？呢個方法？
柯教授用中文問我，用中文答翻你。咁暫時係冇可能，因為太貴同埋太需要長時間。但係已經有人開始睇緊，我哋除咗睇 sputum 入邊嘅 cells， 可以睇 supernatant， 因為 supernatant 嗰度亦都有唔同嘅 cytokines、chemokines 可以量度到嘅。有人而家提研緊就係睇 supernatant 嘅入邊嘅微粒分子嚟幫助我哋斷症到你個氣管係咪有發炎？我相信嚟緊呢5年會有繼續新嘅發展，因為我覺得痰呢一方面其實俾好多資料我哋，但係暫時呢一剎那間咧就係唔可以喺我哋平常嘅工作情況下用到。
或者大家如果暫時諗唔到問題咧，我哋可以遲啲 tea break 嘅時候再問李教授。咁我再次多謝李文霑教授嘅精彩演講。